Thanks for joining us, Sarah. Yeah, good evening. My name is Dr. Sarah Coll. I'm an orthopaedic surgeon based in Cairns in far north Queensland with an interest in upper limb. And today I just wanted to do a GP refresher course on wrist injuries. I'm just going to run through some of the basics. Because I've got two hand therapists, I'd love it if you ask some questions, because I know your questions are going to be a little bit sophisticated, and I am going to share my screen, so I'm afraid it'll be a bit... Okay, can you see the screen? Yep, okay. So I'm just going to tell you about mechanisms of wrist injury, anatomy, common pathologies. Your definition of common might be different to mine. Management principles, red flags, and we're going to talk about, I was going to tell you about my topics for next year, but I can't. So that's another story. I've structured this talk to kind of fill gaps in knowledge that I perceive in GPs, but if you want to ask any questions, just put your hand up. If I ignore you, just shout at me. So I think GPs don't know the name of the bone, so the 8 carpal bones. And to be perfectly honest, I don't mind if they don't know, right? I just need to know if you think it's a metacarpal or a carpal or a forearm bone. I'm going to talk about the carpal bones next. I think the next thing is to appreciate the difference between what we call the radiocarpal joint, which is the main wrist joint, and then the fact that we've got this extra carpal joint, the mid-carpal joint, which becomes relevant when we're talking about interosseous ligaments. The number 3 main interosseous ligaments are the TFCC, which is the shock absorber. So I always try and explain this as a meniscus of the wrist. It's a shock absorber, but it also carries a responsibility for stability. So stability of the ulnar as it attaches to the radius is conferred by the ligaments around the TFCC. The other one that I like GPs to know about is the scapholunate ligament, which is the pain that they have when they say it's right in here, right in the middle of my wrist. And I'm going to talk about the clinical presentation later. And then the last but not least is the lunotriquetral joint, which is just past the TFCC. I try very hard to have absolutely nothing to do with that, but I do understand that it does get unstable at times. And then the other thing I want GPs to learn about is the course of the nerves. There are 3 nerves in the hand. The first one is the superficial radial nerve, which is the one that gets involved when people have de Quervain's surgery, because it's very superficial and very fine, right? And it just supplies the back of the hand. But the median nerve is our carpal tunnel nerve. It goes up under the carpal tunnel and then it splits immediately after the carpal tunnel into the thumb, index, middle and half of the ring finger. Now all those branches are the ones that are potentially threatened by the endoscopic carpal tunnel release, and we can talk about that if you would like to, but the end of the carpal tunnel is when they separate. The other trick is that the nerve to the thumb, so if you're assessing someone for a laceration, the nerve to the thumb doesn't sort of run up like this, it actually runs across the hand like that. So when they've got a web space laceration, they can involve the nerve, and it is worth checking the tip. The ulnar nerve is slightly different. It has its own tunnel, but it's a little bit further across to one side, and it has a very short, sharp tunnel as it dives into the wrist, dives into the back of the wrist, and it can get impinged there, particularly, when they're on their bikes and things like that, leaning on their hands. I think it gets involved in TFCC tears, but that's my theory. So the first thing I wanted to talk about is what is a wrist sprain? And so the grade 1, 2, 3 is, stretched, a little bit torn, completely torn. But I think basically the trick with a wrist sprain is it either gets better in 6 weeks or it doesn't. So the patient falls over and they hit their wrist and they're like, "Woo, that's a bit sore. I think I'm okay." And then sometimes they fall over, they hit their wrist and they're like, "Whoa, that one's broken. I think I'll go and get an x-ray." And they get an x-ray and it's all normal. So it's a ligament injury with no fracture. So they get an x-ray, I've got a normal wrist, therefore I must have a sprain, right? So now it's a sprain, right? The other way they present is they hurt themselves and when they fall or they injure their wrist, and it just doesn't get better. So the patient has an expectation of a certain improvement in a certain time frame, and that is, you know, your other definition of what a wrist sprain is it's those patient expectation of whether or not they're going to be able to use their hand. And so the reason why we use the grade 1, 2, 3, because we, you know, mild, moderate, severe, small, medium, large, it's always very handy to have 3, is because we're looking at whether or not they've got any healing capacity. So the extra osseous ligaments of the wrist, the ones on the front and the back, the ligaments, even if they're completely torn, they often sit in close proximity. So an extra osseous ligament is likely to just sort itself out, even those capsular avulsions that they get over the back. But the intraosseous ligaments, once they start tearing, any, I call it glue, any collagen that tries to accumulate to get the ligament to heal gets washed away as soon as they start moving their wrist. And so an intraosseous ligament tear has a much worse prognosis as far as healing, because it just simply can't glue together. And that's why surgeons operate on anterior cruciate ligaments and why they operate on rotator cuffs, because the ligament is trapped inside the joint and it can't stick itself together. Question about MRI scans is always tricky, and I'm just, in my observation, I'm certainly noticing that more and more patients are presenting with their MRI scan already done. The problem you have as a hand therapist is that the MRI scan is a picture of the wrist, and absolutely the expert is reading the picture of the wrist, but you have that clinical assessment, and it's very important that you provide your opinion on whether or not you think there's more going on than what the MRI might be able to detect. The MRI can see it, but there's still a clinical interpretation required in any imaging, X-rays, ultrasound, and MRI scan. You really have to interpret it with some clinical knowledge. And so sometimes if they get an early referral to an MRI scan, they're a little bit undifferentiated, they've got a bit of a sore wrist. The person trying to interpret those images is struggling to see what the point of the scan is. And particularly if they've got some arthritis, they can zoom in on the arthritis and not focus the reporting on the acute injury. So the most important thing for me as a surgeon is to understand the mechanism of injury, because basically when you do the operation, you're almost just reversing the mechanism of the injury. And so sometimes it's like when something breaks, if you can imagine it, you know, it can rotate or it can break directly. In order to put it back, to reduce a fracture, you kind of have to almost reverse the mechanism of injury. So it's super helpful to hear the mechanism of injury, and also the timing. Sometimes they've had an old injury, they've forgotten about it, fair enough. Sometimes they injure it and then they re-injure it and then they re-injure it. And also sometimes just getting a feel for the rhythm of the injury. One of my mentors told me that all wrist anatomical structures can be palpated, and so therefore you have an obligation to, you know, literally palpate every bone and work out what's the problem and work out what's the ligament. I guess from my perspective, I'm truly grateful that the wrist is subcutaneous, because it really does let me sort of get in there and try and work out exactly what I think is going on. I think if a patient has a range of motion of 50-50, from a GP perspective, I think they're on track. You know, they're doing okay, they're probably going to be fine. But if you're sort of trying to work out, do I refer, what do I do? If they sort of are starting to hit 50-50 and they think they're getting better, that's a good thing. If they won't grip because they've got wrist pain, then you need to sort of reassess, because sometimes that's a ligament problem. And then also for GPs, you know, we certainly need to see a neurovascular examination. And if you're starting to get suspicious about certain fingers, then sometimes it's worth checking certain digits. Obviously, if there's a laceration, neurovascular examination, super important, but it's part of all your musculoskeletals. The Watson test, I think, is a little bit complex. I like to do that with pressure on the distal pole of the scaphoid. Apologies, I've just got a pressure on the distal pole of the scaphoid. And it says to listen for a click, but I am also interested in that apprehension. So when I do a shoulder and I do an apprehension test, when I do a scapholunate Watson test, I'm also, are they trying to, you know, get away from me? Do they feel like it's going to do that thing it always does? So I'm listening for apprehension. TFCC, you can, you know, load, like push out of a chair, carry a suitcase, but I'm always interested in distal radial ulnar joint instability. So what I'm looking for is whether or not I can move that ulnar in relation to the radius. So I just want to see if I can get a little bit of give in that. And sometimes the patient will be a little bit apprehensive, but quite often they're not apprehensive. They're apprehensive about you touching the painful bit, but they're not apprehensive about the joint moving around. And that's where, you know, we talk about applying a widget, or, you know, you can try applying some gentle compression and see if they like their grip strength, but I don't do that very often. Phelan's test for carpal tunnel, Tennell's test for carpal tunnel. Phelan's test, I always do an augmented Phelan's test, which is where I press inside the press right on the carpal tunnel with them fully flexed, elbow flexed. And the reason why I like a Phelan's test is, the reason why I do this test is that it has a faster detection. So a normal Phelan's test that you do, when the traditional one, you have to get them to hold the position for 3 minutes. So what I've seen them do is the surgeon knows this patient's coming in with carpal tunnel. Patient walks in the room, the first thing they ask them to do is to sit there and tell them the history while they're holding their hands in that position. After they've divulged 3 minutes worth of history, they usually are symptomatic. So my preference is to actually listen to the history and then go on to the examination by pushing on the carpal tunnel. And all I'm looking for is any change in their symptoms. I do not need them to completely reproduce all their symptoms. I just want to hear that they've got a sense that something is different about that. So that's what I'm looking for in a Phelan's test. I have a very low threshold of accepting a positive Phelan's test. It's sensitive and it's specific. And then also, I then correlate it with the symptom relief once I've done a carpal tunnel release. So I've got the benefit of being able to check my test against the outcomes. And so the patient who has a positive Phelan's test is very likely to get a nice result out of carpal tunnel release. Patient who has a negative Phelan's test but is really numb is often likely to get a benefit from a carpal tunnel release if you're not too late in getting to the compressed nerve. So once they've had that numbness for 12 months, sometimes I can get a negative Phelan's test, and I think that's because that nerve is really struggling. I'm a huge fan of x-rays. I know it sounds old-fashioned, but I love to see the overall alignment. You often pick up a bit of thumb osteoarthritis. It's always good to know. And sometimes there's, you know, a story in there. Coalitions and all sorts of weird things you can get on the wrist. Just for GPs, that the scaphoid view just really gives you that nice long view of the scaphoid, so you can really zoom in on whether or not you think it's got a fracture. You want to know if it's got a fracture of that proximal pole. It can have a tiny chip when there's a scapholunate ligament injury, or it can have a nice obvious step right across the middle, and then repeat in 10 days if you don't have access to an MRI scan. I don't use an MR arthrogram very often. I prefer to just use an MRI scan, but I certainly would say that, you know, it takes a bit of interpreting to get used to not having an arthrogram. I did use it a lot when I started my practice, and I just found that the patients didn't really appreciate the discomfort of the arthrogram. So I tended to prefer to just use an MRI scan. An ultrasound, I do use, locally use an ultrasound for dynamic ultrasound. You know, sometimes the patient comes in, they've got a funny click, or they're doing something weird, and I can't determine what's the cause of that. I love sending them for a dynamic ultrasound. I just use iMed, and, you know, get them, I try to be very clear about exactly what I want to see on the ultrasound. Is the extensor tendon rubbing on a spur on the back of the wrist? Is the flexor tendon triggering? Can you show me that? Not just say that there's a bit of tenosynovitis. My favourite TFCC tears, I have had a long and passionate romance with the TFCC. I'm interested in ulnar side TFCC tears, which is what this MRI scan is trying to show you. So the MRI scan shows a tear of the ulnar from the fovea, which is the little root where it locks in. It also attaches to that dorsal capsule, which holds the ulnar in place. The TFCC is the load-bearing meniscus for the ulnar half of the hand. So it captures the hand when they go into ulnar deviation as soon as they want to pick anything up. and it's incredibly important in their grip strength. I think they injure it in all sorts of different ways. They fall over, they twist, they lift. I've heard everything. And they tend to focus on the ulnar side. I think they have pain up and down ECU. They also get paresthesia into the digital ulnar side of the hand. And they can sometimes detect a click, but not universally. It depends on whether or not there's a click in the distal radial ulnar joint or whether or not there's a click on the TFCC as it moves around. What do I want to do? I do like a widget, as you all know. I like a widget because it gives me some idea of whether or not they have a TFCC stability problem or whether or not they have a whole wrist problem. So if they come back and they say, no, the widget was no good, I wanted to wear a thermoplastic splint, then that's fine. Sometimes they won't like the widget if they've got a dorsal ganglion. They just find it too uncomfortable, and I totally understand that. And sometimes if they've got a lot of ECU sheath tenosynovitis, then they don't like my widget very much. I try and tell them to avoid rotation to get the initial symptoms to settle. I love an MRI scan. If they have persistent pain, and I'm happy to wait 3 months, 6 months, I do not mind. I had a lady who came back after 2 or 3 years. She had modified her gym routine for 2 or 3 years, but she just didn't have time to take time off. And then she allocated herself time off, she did the rehab and went back to the gym. But she just couldn't change her schedule up. And I was happy with that because she had worked really hard to protect it. And so it felt like when I was repairing it, there wasn't any collateral damage, not collateral ligament, but collateral damage from around having that TFCC tear. Scapholunate ligaments, I had to include a picture of Terry Thomas because Terry Thomas is the X-ray sign that you can see on here. Terry Thomas was a very old, famous actor and had a big gap in between his front teeth. And so that's why we call the scapholunate ligament rupture a Terry Thomas sign on the X-ray. It is a high velocity injury. I certainly find it's more like a scaphoid fracture. So it's like motorbikes and flying through the air with their AFL and things like that. And that MRI scan, I don't know if you can see, but the scapholunate ligament is torn, as is that ulnar side of the TFCC. And I think there's almost like a dislocation pattern through the carpus, through the TFCC origin. So scapholunate ligament tears always worry me because they just, they're a high energy injury. This patient can have acute carpal tunnel syndrome. They can have a very puffy, very weak hand. They're really struggling to work. If it's acute, they're really struggling to work. And there are 2 ways of looking at it. They can have a partial tear, which I can do with a repair. I can address that with a repair, just simply reattach those ligaments back onto the bone. Or they can have a full and then a more chronic chronic injury, which means that they've put up with the clicking and popping and they tried to get back to work and they just don't feel like they have the strength. With that, I use a tape suture to reconstruct the ligament. Ultimately, if it's arthritic, they get a wrist fusion, but we can talk about that in a second. I just wanted to share
Sarah?
Yeah.
Sorry, do you ever get the clenched fist X-ray view to help ascertain the Terry Thomas sign?
Yeah, look, you're right. I like that clenched fist view. I just, if I send a patient for it, I do educate them. I say, I understand when you squeeze your fist, it's going to reproduce the pain in the back of that wrist, but that's what I'm looking for. So I do educate them to not kind of grip and then, like you can curl your fingers in without really clenching your fist. So yeah, I like that as certainly it shows you that as soon as the wrist is loaded, it's not functional. It's a functional examination, much better. It's just, as you know, everyone jumps straight into the MRI scan. It's the way it's going. Reconstruction or fusion. I just wanted to share some images of wrist arthritis because I quite frequently get referred patients with significant wrist arthritis, which has sort of been a little bit underappreciated, mostly by the patient, but also partly by the referrer. Because an arthritic wrist can be quite significantly arthritic without much visible deformity. And I mean, I can see it, the wrist sort of gets a little bit short and sometimes it swings into radial or ulnar deviation, but it's hard for the patient to really appreciate that they've got wrist arthritis until it hurts. So I often have to go back to the x-ray. So the top right hand x-ray shows you a slack wrist. So that's where the scaphoid and the lunate have come apart and the capitate is now driving down between the scaphoid and the lunate to hit the radius. And so I don't know if you can appreciate, but the scaphoid is now grinding in, you know, like in a mortar, a pestle in a mortar is grinding into that radius, and that radius is basically buttressing itself up against that ever toughening scaphoid. The next one is a snack wrist, which is where there's actually been a scaphoid fracture that's been untreated. And look, you know, the screw fixation of the scaphoid fracture only really came out in the 70s. And so there are a few of these guys sitting around. To be perfectly honest, there are plenty of guys who break their wrist, break their scaphoid and absolutely have no recollection. I just want to draw your attention to the final x-ray in the middle with the two hands and just really appreciate the complete dissolution of any carpal bones in there. I really want you to see that you can't see much of the distal radius, you can't see much of that distal ulnar. You can see the metacarpals and you can see the bases of those metacarpals, but as you can see in the early days of wrist surgery, you can see why we would fuse these wrists, because they basically fuse themselves. These joints are so badly destroyed that they fuse themselves. And I have seen young people in an acute setting get an autofusion, so a fusion of their bones spontaneously. And so yes, osteoarthritis, joint space narrowing, osteophytes, subchondral sclerosis, subchondral cysts, same as everywhere else in the body. What do I think about arthritis? The short answer is we have two main primary procedures, so we call them partial procedures, and then we have one main final procedure. Proximal row carpectomy is in the top right hand corner. You can see that the proximal row, we talked about that at the very beginning of the talk with the two rows of the carpus. The proximal row, scaphoid, lunate, and triquetral, are removed. Okay, so they are completely removed and the joint articulates on that capitate. You cannot do this operation if there's capitate arthritis. So if the capitate is also involved in the osteoarthritis, you can't do this operation because they'll just come straight back in with capitate radial arthritis. And then in the bottom left-hand corner of the screen is what's called a four-corner fusion. So this is where you leave those proximal row on the ulnar half and you remove the scaphoid. You can remove all of the scaphoid. Some people remove half of the scaphoid and then you apply a plate to the ulnar side of the wrist. And then the articulation is basically through the ulnar half of the wrist. But I think if you look closely at that x-ray, you can see that there is osteophytes on the ulnar head. There's osteophytes on what remains of the lunate. So the ulnar half of this wrist is still slightly arthritic, which means that it can be a pain generator. So either option has a risk of post-operative pain, but maintains some movement. So if the patient's priority is absolutely categorically movement, these are the options. But I must say I really try very hard to avoid that option because I feel like I need to articulate carefully to the patient that the ultimate cure of wrist pain is to fuse their wrist, and that's what the photo is in the middle, and that's why there's a beautiful photo instead of an x-ray. So the benefit of a wrist fusion is that they then have a strong grip, but they need a better elbow, they need a better shoulder, they need to be able to reach, they need to be able to manipulate their hand. And I've warn people who have to reach around behind things such as electricians, air conditioning installers, that they might notice a difference in that. The last electrician was perfectly happy. So who knows? Now, there is a chap in Newcastle who is doing wrist replacements. He's super happy with them. He's presenting his findings. He continues to be happy with them. Not many other surgeons are taking it up, so it's a bit mixed as far as our preference goes for wrist replacement. One of the issues we have with wrist replacement is there's not a whole lot of bone stock in order to put the implant into, and the patient doesn't just want flexion and extension like a knee. They want to be able to do circumduction. So they're always pushing this implant to get that nice movement. So the implant actually looks more like a hip replacement and less like a knee replacement, because they're really trying to lock in a stable articulation that gives them circumduction. Watch this space, it's coming. Carpal tunnel, neuropathic pain sometimes, mostly pins and needles. Pins and needles, tingling, numbness, wakes them up at night. Weakness of the thumb, not so important as they tend to say they drop things. I definitely see wasting of the thumb when they're osteoarthritic. So if they've got an osteoarthritic thumb and carpal tunnel, which tend to go together, then they'll have a wasted thumb. So you don't always have to panic about the wasted thumb, but I do educate them that I can do the carpal tunnel release. It doesn't necessarily give them their thumb muscle bulk back, but it might. So initial management, rice. The guy that invented rice has said that, you know, he doesn't believe in it anymore. He's not sure that it is the answer. So I always like to put that up there because, of course, you know, we do all these things instinctively. Immobilise. I'm a big fan of self-directed immobilisation, certainly in an early presenter. If they are really sore, they'll put it on all the time. Analgesia, anti-inflammatory, slow healing because they reduce inflammation. Inflammation is the first step on the road to healing. Activity modification, obviously I see a lot of work cover patients, so we've got to put that in the work context. A little plug, you know, hand therapists are different to your standard physiotherapists. A lot of physiotherapists find it very challenging dealing with hand conditions, and so I want the GPs to be confident in referring to a hand therapist. If they feel like the physiotherapist, you know, they've done their shoulder and now they've done their elbow and now they're up to their wrist, sometimes the physiotherapists just want to tell us that it's just a bit much for them. I like early reassessment. Look, you know, it's hard to tell GPs that we want people to keep coming back to them. So I do try and get the patient to self-initiate a reassessment. I always ask people, I say, I've got an open door, please come back if there's any problems. Come back on this date. If you don't need me and if you're really confident, please don't come. Pain persistent for more than 6 weeks, instability or weakness, so they're trying to grip and they can't, abnormal x-rays, neurovascular compromise. Red flags. Look for the small wounds. Sometimes they can have little tiny puncture wounds. Sometimes the little fractures will give them little scratches on their skin. Snuff box tenderness. It kills me, but the MRI scan is the best assessment of a scaphoid fracture. Distal radial instability doesn't settle quickly. If it doesn't settle easily, refer. Weakness and paresthesia acutely is important. And I think key takeaway, sprain is a ligament injury, often settles. Doesn't mean that there isn't something going on underneath. X-rays can lie, especially on these teeny tiny bones. Early referral for true ligament injuries because you're trying to prevent osteoarthritis, in theory. Consider carpal tunnel as a confounder, and the function is more relevant than the imaging. There you go. Kerry, that's one for you at the end. And based on this morning's journal club, can I repeat that I used AI to generate my talk? So please, ask away. Ask me any questions. So that's a full confession there, Sarah. You missed it at the beginning.
How quickly do you like to get them, Sarah, if there's an obvious thing that's going on?
Oh,
so like...
Yeah, if you sense instability, don't be sitting on them. You know, if you sense that they can't grip because they're unstable. But remember, you know, I would think about it as a hand therapist, I would be thinking about the rehab. If this patient is not in a fit state to cope with that rehab, because you know exactly how long the rehab's going to take. You know what that journey is going to be like better than I do, because I only see them once. You know, if you feel that they don't have the physical capacity, the support, the emotional resilience to go through that whole rehabilitation process, I try and find that right at the beginning. Like, you know, what am I committing this patient to? Because they don't know. They can't know. you know. So yes, instability. And what I mean by instability is sometimes pain. Yeah, go on.
Yeah, no, I agree. Yeah. What about thumb, on the collateral ligament?
Yes.
Do you want to talk a little bit about that for the
Yeah,
GPs? Because I think that
yeah.
sometimes they're in a tricky spot of not really knowing exactly when to refer.
Well, I think, they're taught that, taught how to test the ulnar collateral ligament, but I don't know about you. You test the normal side and you test the other side and you're like, no, wait, let me go back and I'll test the normal side again. Oh, and I'll test. So yes, people can have very supple metacarpophalangeal joints of their thumb. So I'm always a bit cautious about, I've got to compare both sides, and then I just do an MRI scan, which I know it's cheating. But localized tenderness, especially to the ulnar side. I do a little bit of radial collateral as well. I think radial collateral ligament tears are often more mature patients. So I think that's more an overload, gradual attrition, and then they get the injury on top of it, right? So the RCL sort of goes slowly, like it kind of stretches and then it's gone. Whereas the UCL, absolutely, down they go and then they tear that UCL of their thumb. There's a lot of talk about the steno lesion, and obviously with the steno lesion, you can get that on an ultrasound. All you need is an ultrasound to detect that. Once they've got a steno lesion, well, all bets are off. They're probably not going to heal it themselves. But if they don't have a steno lesion on ultrasound, then lots of splinting.
Yeah, and I would generally say, well, maybe I'm biased because I'm a hand therapist, but you can't pick one of those splints up at the pharmacy. They need to see a hand therapist. It's usually a custom-made thermoplastic splint. Yeah.
Well, speaking from personal experience, when I did my UCL, I was still trying to use a drill because that was my job. And using a drill is excruciating. It's much better if you could use it with the brace on, but, sterile. And so the problem with the brace was that you get pain here, right? Because the brace rubs. It does not rub. It's because I kept trying to use my hand and push as hard as I possibly could against that thermoplastic splint, until I would just wear a hole in my skin because my thumb would not do what I wanted to do it because the splint was stopping it, right? So I used to, and then the other secret that I will never repeat again is that, you give those nice Velcro straps. No, I needed the D rivet things, where they rivet, they screw it into the thermoplastic and then we reefed it on because I was just I was so active with my hand. It was still unstable, but as soon as you give me function, then I'm going to push into that and then push again, As soon as you put some padding on the inside of the thermoplastic splint, well, then I'll just use it more because it's, you've made it possible. So yeah, highly successful, perfect treatment option. But I'm always here as backup. Go on.
But definitely, if there's a steno lesion, it needs surgery, doesn't it?
Look, I think they'll have that persistent instability and weakness if it does all sort of glue together. It's quite tricky, especially if it's late. It's quite tricky to kind of work out where everything's going once there's a steno lesion, because that piece is flipped on itself. Well, it doesn't just decide it's going to flip back. It's actually scarred down hard, and to try and find that cleavage plane between the two halves and then flip it back is not fun, and it's microscopic and you've got your loops on. So yes, if you think it's a steno lesion, it's nicer for us if you refer early. But if it's not a steno lesion, you persist, because we can always, if it's just a UCL avulsion, I can always find that and put that back on. That's not challenging technically. But if it's a steno lesion where it's twisted on itself, then suddenly my ligament's too short if I take it from here. So I actually have to unfold it to get it to stick to the bone, and that is not nice. Does that make sense?
Yeah.
Sarah, did you have a question? I felt like there was a question before, or a comment, of course.
I was going to ask, when do you typically advise people when they can return to sport? Maybe specifically like with soft tissue injuries. I find that's always a little bit tricky.
You mean in the context of a wrist sprain? So they've been diagnosed with a wrist sprain?
Maybe while on the topic of like UCL, maybe like
Yes.
ligament injuries, including thumb.
So for a UCL, I would be assessing the instability. You know, as soon as I felt that the instability was the same, go for it. Because what are you waiting for? You're just going to get muscle atrophy. Do you know what I mean? So as soon as you feel, so depending on the patient's engagement, you know, if they want me to check it every week, I'm happy to check it every week, but they've just got to come and see me, right? So I would start looking at about week 4, you know, do I really think that this is pretty similar? And once I detected that it was, you know, very close, maybe I'd give myself an extra week. But it's an extra osseous ligament, right? So it's like a wrist sprain in that, you know, it's sitting there. It's sitting on the bone. All you're trying to do is get that tiny little bit of collagen between the ligament and the bone. So you're not expecting much for a standard UCL. So for a return to play, well, what are you waiting for? Yes, the fibers align better. Yes, it probably can take more load. But, you know, I also try to give them advice that means that they're not going to lie to me about whether or not they took my advice. So I'm trying to keep the relationship, you know, open so that they can come back and tell me if they re-injure themselves, because I want to keep the door open. So wrist sprain, the problem is, you know, I clear them to return to sport and I have no idea what they're going to do when they get out there. So now I just make them do push-ups. Show me a push-up. Oh, I can't do that. Can't play, can you? Do you know what I mean? Like, you know, show me. And, oh, you know, if they've got a shoulder or whatever, I think it feels unstable. Well, can't go back. So, the problem is that they're so keen to go back. They'll say what they think you want to hear. But so therefore you've got this obligation to kind of hold them back a little bit. But, you know, if they can show me that they can fall onto their hand, great. Do you know what I mean? Like a young person should be able to fall forward and, you know, sometimes they, you know, fall against the wall, you know, fall against the bench, and then, you know, can you show me whether or not you can jump with a push-up? So, you know, if they really want to play, then they've got to be able to do that. But if they know they can't, they'll tell you. Go on, Sarah. Did you want something more specific in that answer?
No, that's good. That's good. Thank you.
I'm running out of puff. And I promised myself I was only going to talk for half an hour, so but I was wrists. I love talking about wrists. We've had so much advancement in the last 15 years. It's been so good. There's a lot of procedures for the scapholunate ligament, which just for the hand therapists, which are simply designed to take that capsule and make it really tight. So you end up with them stuck in a little bit of extension because that's your power grip, and it's like a black capsulodesis, all of those sort of words. It's just tightening up the back. So if you spend a whole lot of time stretching them into flexion, it's not good, right? So we're always, you know, I said 50-50. So I always try and stop at 50 of flexion. If the patient gets more, fabulous. But I don't, you know, when they do the scapholunate ligament, it is a restrictive procedure. It's not always designed to get full flexion. It's designed to give them power into extension. Does that help?
Yeah, I think once I got that straight in my head years ago, I was so much better because I just don't have to push that, because I just knew that wasn't where I wanted to go. But yeah, you know, to protect that, so avoid flexion. When
they get a wrist fracture, they get that little kick up of dorsiflexion. So I have seen, a patient work hard enough that they actually started to sublux their mid-carpal joint, right? Because they were really working hard on flexion, and they were like, why does it hurt down here when I broke it here? I'm like, just... Thank you. You got plenty of flexion. Let's just leave it, you know. Do you have to have 90 degrees of flexion? She just got on a roll with the therapy, and I was like, no, that's it. Because when you get a distal radius fracture, the normal radial tilt's 10 degrees forward. Once they've got 10 degrees back, they've actually lost 20 degrees. And that's just in the bone, that's not the soft tissues. So if you're trying for 90 degrees of flexion, you're not going to get it. You're probably only going to get 70, even 60.
Yeah, I think the new work we do as therapists using wrist proprioception so that they're much more aware of their wrist position as they go to do things, and really consciously training neutral wrist position so that they're not immediately working into weird patterns of movement is really good. And then they go away knowing what they can do, and they can make it up on their own then, because they know what the standard position they're trying for, that the starting point is. So, yeah, it's complex though. It is really...
Yeah, I hadn't really thought about teaching them how to avoid that ulnar deviation. I really like that. The other one is the Birmingham wrist protocol and the differential strengthening. Do you think you're having a win with that? I mean, it's been around 10 years.
I kind of blend those things together.
That's what I thought you might say that.
sensory motor retraining kind of stuff, I think, is what you're talking about. And that it's basically using proprioception as part of it, and using strengthening, but very targeted strengthening of very specific groups, so that the tendons act to help stabilize the wrist ligaments, and they're not constantly working into a more difficult position. Because I think the wrist ligaments get a bit dismissed. It's just a ligament strain, but it's like, can I have a fracture instead, please? Because at least I know how that heals. And wrist ligaments are very naughty in that they have really limited blood flow often, don't they? And they are harder to get healed, take much longer time to get really strong again. So, and I think sometimes it's that tricky bit of we knew, there was a fracture there, but it wasn't really obvious until couple of months down the track, that when you're really starting to get them going, that there was also a ligament injury that hasn't quite finished. Yeah.
True. Yes. Yeah. Even that sort of, you see those little tiny chip fractures off the distal radius, and you think, it's, what are they so worried about? But I think, that's a marker of, a more extensive ligament injury. And I think, as you say, it gets dismissed. It's just a chip fracture. And in fact, they, in order to achieve that, they've actually had to, deform their wrist quite a bit.
That's what we see that a lot with our distal radius forceps. You get to the 6 to 12 week mark, and their main complaint is the ulnar side. And then you go back to the X-ray, and there's an ulnar styloid fracture.
Yes. So you've got a TFCC injury. Back in the olden days when they taught me, someone did a study that said that they all have 30% have ulnar side pain for 3 months, right? And that was it. Like, okay, Barley's, so what? It's like, well, do we address this? And then it sort of said, no. After 3 months, it all goes away. Then they're perfectly fine, right? And they come in and so you can do that ulnar shortening procedure, which I quite like if I've got quite a badly smashed up TFCC. I love an ulnar shortening, but repairing it is so rewarding, because they're like, yes, I understood I broke my wrist, but actually I feel so much better now. My TFCC is feeling better. So and also, of course, the issue with the ulnar styloid fracture is that it's really hard to get it to stick.
Yeah. And we've started, like with most of our wrist fractures, like distal radius wrist fractures, we're not really giving ulnar deviation, radial deviation as an exercise. Because it's just flaring up patients' pain, and we're finding that it comes back naturally within return to function anyway. And like Terry said, like a lot of these, the TFCC, teaching them that neutral wrist posture is like a game changer for them. They have instant improvement in pain levels, because they usually let it sometimes they let it drop a little bit to offload the pain they're getting at, and so then they start loading the wrist in that position. Yeah. That obviously flares up their pain significantly. So when we teach them, like, no, you have to load it in that neutral position, it's usually like they have instant improvement in pain symptoms.
That's good. Okay. Yep. I can use that. That helps. Because like I say, it's so common after a distal radius fracture, and they just, Just this week, I saw a lady, Kerry, who came in with a wrist fracture that was 3 weeks old, and she was like, "It's hurting, right?" This was not tender. So here she is, 3 weeks into a wrist fracture. She has no distal radius tenderness. She's like, "What did I break here?" Oh, yeah. Well, there is that ulnar styloid, right? But she was only 3 weeks after a distal radius fracture, and I can't tell you, in her 50s, and no tenderness, right? So she can get her wrist going because her fracture's united. And that's at 3 weeks. So
yeah. Problem is that one has got a significant swelling and a definite brush with CRPS. So, I misjudged
CRPS.
that one.
We can do a whole talk on CRPS, Sarah.
Yeah.
We're talking about CRPS. Go on.
I felt I needed to caution her to back off and not start doing things that she shouldn't do. But she's in fact
She's a bit recalcitrant, Kerry.
She's a tricky person. So, fingers are getting going a bit more now, but there's still a huge amount of stiffness and very much swelling in those fingers.
I think she was protecting her TFCC she was trying not to move her fingers to protect her TFCC pain. So it was just I think she's like, it's the fracture. I'm like, and I wonder, well, she can't really drop into ulnar deviation and then move them. But I wonder if you could get her to come into a bit more radial deviation to get, I don't know, she might make...
Yeah, we remade her splint so that it was just sitting slightly differently. I think it needed remolding at that point because the swelling had changed somewhat, and she was doing better in a compression glove when she was wearing it versus just tubie grip. So, yeah. But interesting what you pick up from a photo that someone sends you, and I'm going, "Are your fingers really swollen?" She's, "Oh, yeah, I just didn't want to bother you."
You want to move
them. Come and bother me. Yeah, come and bother me.
Come and bother me.
But also the other issue was that there'd been a previous shoulder injury that has not yet rehabbed properly, and that made it really difficult to use the arm because it wasn't going anywhere when she tried to move it.
Yeah.
Anyway.
And the incidence of frozen shoulder after these wrist injuries in these women is off the charts, They just get over their wrist and then they fall into that frozen shoulder. Proximal humerus fractures, wrist fractures, the whole lot. They freeze their shoulders so fast. It's very sad. Adash, do you have any questions? Do you have any comments? Any contribution you want to make? Feel free. Butt in. I'll take that as a no. Otherwise, we're going to restart the talks back in February next year. Some might be in person, some might be online. I've just set up a whole series of topics I was going to give them and see what people wanted to talk about, because I don't really mind what we talk about. I just like talking about work.
Me too.
Yeah, it's pathological. Yeah. So thank you all very much for coming, and I'll end the meeting and stop the recording. Lovely. See you next time.
Thanks, Sarah.
Thanks, guys.
Bye.